Well, thank you for that wonderful introduction, and it's really my honor to be here with you this morning. I believe that we share a lot. Whoops, I gotta turn this on, right? Yeah, there we go. I believe we share a lot in common, and I have to say that for me, visiting sites and talking to people is a great way of learning. It's just the time being away from the Institute. What I plan to do over the next hour, really 45 minutes or so, is give you a vision of what NIMHD is about, give you a sense of where I think we're going, and then present some big picture health issues, and also share some of the projects that we have funded, of which you've mentioned a couple. I'll just use them for an opportunity to say a few things. I'll start by talking about myself. No, these are not the first winters in Washington. I actually spent 6 years of my childhood in Pittsburgh, Pennsylvania, and the winters there were much more snow than I have experienced in Washington in 2 years. So I am an immigrant. English is my second language. That's always my excuse when I stumble. I was always legal. Being from Cuba, I was a refugee, so had none of those issues many years ago. I trained in primary care internal medicine, for which I feel very passionate about. A general internist is a primary care doctor who manages from healthy to very complicated patients. I gave that up by going to NIH, that is being a primary care doctor, but I thought the opportunity was too good to pass up. I did research fellowship at UCSF at a time when this whole field was really developing. We didn't have computers. Statisticians were our basic scientists and epidemiologists, and we worked with social scientists as clinician scientists. I got an R01 when I was 33 on tobacco control, sort of the right place at the right time. Would never happen now, of course, because I hadn't published anything. And then my career, as you heard, focused a lot on cancer control issues, minority health, aging, and diversity issues, and ended up at NIH in September of 2015. Amy had asked me to say a couple of things about what had I learned. How was it to transition to government and a leadership role, and a different leadership role? So, and after 19 months, officially it was 19 months on Saturday that I've been in the job, I can share a few highlights. First, government is actually much more efficient than most people think. Even though it has its problems or its barriers, the academic institutions do not stay far behind. Second, I had to get used to the hierarchy issue, because in academics, although you're a chief or you're a chair or you're a director, faculty do whatever they want most of the time. And if you try to sort of lay the line on something because something's really outrageous, sometimes that gets you in more trouble than it's worth. So a lot of times people are very passive about avoiding conflict and not following, not getting a hard nose on anybody. And at NIH, one of the directors said, well, if you come here and you say, gee, I wish the ceiling was green, the next day it'll be green, because you're a director of an institute and you really have authority. And that's something that I had to get used to. I wasn't used to that. And so to temper that, because it's a really top-down structure. And to try to make it more interactive at the same time that I know I have the authority that I can implement. All institutes are autonomous, so every one of us is really appropriated by Congress. So we really are autonomous. Now we have a director overall of the agency, but reality is each institute is an autonomous republic, and you make it what you do make it. And so I think that's another opportunity, really, even in a small institute like NIMHD and measured by budget. I still have a seat at the table with the rest of the directors. All politics are local, and at NIMHD there's a lot of politics, a lot of sensitive politics, maybe not the kind that are dominating the conversation now, but certainly important historically and to both the leadership of NIH as well as to the people in the United States. And so I think being in that situation for me was relatively new, and particularly, I guess, dealing and learning about American Indian tribal issues, I think has been one of the areas of which I have learned the most over the course of the last 19 months. At NIH, there's a tremendous passion for science, and I think this is something that is extremely attractive for those of us who come from that background. There's a passion and respect, and it's a data-driven organization, and I think perhaps unlike many parts of government, people are clear on the mission at NIH, and I think that's a very rewarding sense of being there. There's a tremendous collaborative spirit. I have not encountered any director of other institutes who have been, oh, your institute is, that's not really science, it's just political, or the kind of prejudice or bias that you may think could happen. Not for 1 second. And in fact, they have been out of their way supportive and collaborative. And finally, I think we are at a point where recognition of minority health and health disparities as a research field and the scientific contributions that we can make, not just in terms of our populations in advancing the health of our people, but also to knowledge, I think are becoming more clear to everyone around us. Briefly, our history started in 1990 under Dr. Sullivan's being Secretary of Health and Human Services, when the Office of Minority Health and Minority Health Research was opened in the Office of the Director. In 2000, it was moved to a center, which was the major change. It allowed us to then give grants. And as part of the Affordable Care Act in 2010, NIMHD became an institute. It was elevated from a center to an institute. It was also language in that bill that founded minority health offices in each of the agencies of the Department of Health and Human Services. So FDA, CDC, Center for Medicare and Medicaid Services, etc. Dr. John Ruffin was the director through all these entities until he retired in March of 2014. Dr. Maddox became acting director, and then I started in September. Our budget in 2016 with a boost was at $280 million. This year we're on continuing resolution. We don't know what the outcome will be. We're likely to see a slight reduction, and the process for 2018 is just beginning. Oops, went the wrong way. So our mission is really to focus on minority health understanding and advance the health and prevent disease of all the racial minority groups in the U.S., racial and ethnic groups, and support to understand the causes and mechanisms that lead to interventions that reduce these health disparities in specific populations. We're also very committed to diversity of the workforce, although our institute has a small portfolio on training. I want to emphasize the distinction of minority health and health disparities. So minority health is anything and everything that relates to one of the minority racial ethnic groups in the U.S. as defined by the Office of Management and Budget. And we believe that all minority groups in the U.S. share a common theme of being subject to discrimination. Now this varies tremendously. We know the legacy of the burden of the legacy of slavery in the U.S. for the African Americans, and we know the history of the American Indian people and the wars and the genocide that was carried on by the U.S. and prior colonial powers against indigenous peoples throughout the entire hemisphere. This is not the same as what others have experienced, but we have this common theme that we share, and I believe that's ongoing today. You're all familiar with the OMB race ethnic classifications. I think I haven't met too many people that absolutely love them, but I encourage everyone to use them because this is what we're guided by, this is what we use, and I think if we all did basic things the same way, it would advance our ability to understand and have knowledge. You can always do sub-categorizations among these. Be aware that for 2020 there are two important proposals on the table. One is to go back to a single question of race ethnicity because it turns out that Latinos don't understand this issue of race-ethnicity differences, and about 40% put other, mostly because they said, I already answered, I'm Latino, so why do you ask me again? And the other is adding another ethnic group to this list, which is Middle Eastern North African, who are currently categorized as white. You're familiar with the heterogeneity of the Asian group, and in fact, probably South Asians should probably be a separate ethnic group as well, although the census hasn't proposed doing that. The diversity of tribes among American Indians, Alaska Natives is well known to you. Native Hawaiians or other Pacific Islanders are not Asians. This is a very common mistake, and we really should proactively ask people not to do this, even though we still see lots of reports with these combined. And there is great heterogeneity, but also a lot of commonalities among the Latino Hispanic population that we could discuss about if you're interested. Now, health disparity populations then we're authorized at NIMHD to say who is a health disparity population. I have that authority as director in collaboration with the director of the Agency for Healthcare Research and Quality. I'm sure Dr. Collins wouldn't want me to declare it without consulting with his office first. And you know that all race ethnic groups are disparity populations. We also are interested and have a disparity population target of all poor people, regardless of their race ethnicity. So poor whites are in our target population for grants and for research. For a variety of reasons, rural residents are also included in our target population, although we believe the majority are either minority or poor, but still they are a special emphasis. And I think in recent years, in the past year, there's been some new data revealing disparity among rural residents, I think, which is worth further pursuing. And last October, we made a declaration that sexual gender minorities were a disparity population. This is for NIH research purposes. It got cleared and vetted by the Department of Health and Human Services back then, and there is now an Office of Research on Sexual Gender Minorities that has started under the Office of the Director at NIH, as well as an Office of Tribal Health Research that has a new director as of February as well. Disparity then is defined for our operational purposes as a difference in one of these groups that adversely affects one of these disadvantaged populations. So white men have more heart attacks. That was true when I was a resident, and it's true today. That's not a disparity. That's a difference. But if a disadvantaged group has a worse health outcome, that's a health disparity, and that's what we're looking at in that context. And so our science is devoted to knowing why these things happen, so defining mechanisms of how we end up with a disparity. And I'll get into that a little bit more. I think this is an area that has not received sufficient focus scientifically. We're all eager to do something about it. And so we want interventions that work. But I think the way to get to interventions that work is to know why we're seeing this difference. Sometimes it's obvious, but sometimes it's not. And I think the basic research of understanding mechanisms is one where I would certainly encourage that we emphasize. We came up with these 4 categories of outcomes just to be able to compare apples to apples, as they say. So the higher incidence or prevalence is an obvious one. We also can say that mortality is an obvious one, so either premature or excessive mortality. So early onset mortality is an important outcome, even if the total mortality is not different. Some global measure of burden of disease, like the disability adjusted life years, that has been mostly developed and applied to global health issues, but is increasingly going to be relevant to local areas and regional areas in the U.S., is important. It allows us to compare the burden, let's say, of back pain to cardiovascular disease. Cardiovascular disease kills people. It's easy to get a measure of mortality. Back pain doesn't usually kill anybody. Yet it is the 3rd leading budget item on the Medicare budget in the U.S. today, chronic back and neck pain. And then the 4th bullet refers to anything and everything that patients or people report. So after all, we're in this business not just to make people live longer, but to feel better. So if we get a study that shows that you decrease depressive symptoms, or you make quality of life, health-related quality of life better, or people function better, or have less pain from their chronic disease, I think those are all valuable outcomes that we ought to be targeting as well, and worth developing interventions for. Complicated bunch of processes, but I'll dwell on this as sort of the laboratories where we think things are happening. If you think about where most of the research in disparities has happened, it's happened in that first bullet under individual behaviors. People have focused on, well, what's the individual doing? What's a lifestyle like? What are people's beliefs? But yet, we also know now that the whole response to stress is important. What does racism and discrimination do to individuals' health? Not just now, but later. What about adverse conditions early on in life? We now understand that in that -9 to +3 years period, so much happens that's so important, not for age 5 and 6, but also for age 40, for onset of diabetes and cancer and heart disease. And I think this is a critical area that we need to focus on. And then understanding the importance of things like being a witness to violence, or having food insecurity, or housing insecurity, the stress of immigration, or not speaking the language. In the last 20 years, there's been an explosion of information in two very different parallel fields. One is biology. Everyone's familiar with the Human Genome Project and how scientists are always coming up with new techniques and new discoveries, and as population scientists, clinical scientists, or social scientists, we need to be aware of what's going on in biology and see how that fits into what we're doing, just like they need to be aware of what people have been reporting. And so guess what? The measures that were developed 40 years ago that measured stress, now we know that there's physiological responses that are measurable and that we can now use in our studies going forward. So getting together with what is genetic susceptibility, what is social, what is epigenomics about, and metabolic differences, and what about metabolic pathways that may differ as a consequence not just of your genetic background, but also of your environment. And then the other parallel field that has really exploded is the physical environment science. So understanding how important place is to health, how important the physical structure of the community is, and linked to that, although we've known more about this in the past, the cultural environment, so the social cohesion that communities have. So there is some belief in some circles that all poor people do poorly, and we know that's not true. There are very poor communities that actually have reasonably good health outcomes. And so what is good about that? How do we study that? How do we understand those mechanisms? There's a power to social interactions that we forgot about. Back in the 1970s, before there were statins and aspirin and revascularization, we knew that if a man had a heart attack and he was married, because of course the studies were only with men, that he lived longer. And why was that? Well, social support. What's the power of social interactions? How good is it to talk to people, to know your neighbors, to have some cohesion in a community? And I think, again, capturing this from a scientific perspective to be able to help us understand pathways and explain outcomes, I think is critical. And finally, the clinical laboratory. As a primary care clinician, I do value that area tremendously. I think it's an important area where disparities may be exacerbated or generated, as well as reduced. And because a lot of people live with chronic disease, the healthy person may not go see the doctor very frequently, may not need to, and may be better off not going to see the doctor. But someone with a chronic disease does need to go see the doctor on a regular basis, and it helps control and manage their condition, even though they may be very activated. So I think this is a critical area that we at NIMHD are also very interested in. This is up on our website now, linked to the recent funding opportunity announcement on the centers, but tries to capture this in a sort of a global, simplistic way. And this is not intended to have causal relationships or arrows pointing in the direction of cause-effect. This is really just a display and a framework of the complexity of the kinds of topics that we're dealing with. Now, not everybody, in fact, nobody really does everything here, right? So you find your research is in which box, and how does that relate to the research that your colleague does that might be in another box? And you may need to do some in-depth work in one area before you're ready to expand and interconnect, as Dr. Elliott was showing with her. Let me switch to the issue of inclusion. About 30% of NIH-funded studies with human beings now are with minority groups. The participants are one of the OMB category minority groups. It is still a messy data set, so I wouldn't say that we've achieved success. We're still a higher proportion of the population. But historically, have been underrepresented in research, and there are some big studies that account for a lot of this, so we have to consider that. Inclusion is important. It isn't minority health research, it's inclusion. And I think this is one of the messages that we've talked about at NIH in the past year. Important, and we totally are behind it. But some investigator says, I'm going to have a study with 30% minorities, so that's minority health research, right? Wrong. It is what you should be doing. It's inclusion of participants. It's often good science, because there are things that would not be discovered if you did not have minorities involved in the research studies. And there are a number of examples I could go into in the questions if you wish. It's also common sense and social justice. All of these are relevant in this context. We have to be at the table. You know the saying that if you're not at the table, you might be on the menu, right? So you don't want to do that. We know that it's harder to do. And you know, all the 4 years I was on NIA's council, I did not see a single grant get any negative comments because of their plan to recruit. It was always a checkbox. Yeah, they did it. And yet, no accountability. Now we have the systems that NIH is going to begin to be able to do more accountability on this. So if someone said, I'm going to recruit 30% minorities, whatever group, or 40, and then in the end they end up recruiting 10 or 15 because they had a hard time getting to the groups and they just had to get their sample size. So hopefully we'll get to a better sense of that. It is also hard to say, well, what's the empirical evidence that this is what you need to do? You have investigators say, well, tell me what we're supposed to do to be successful to get to minorities. And to generate empirical evidence on that is hard. I think there are a number of studies, and some things seem to do better than others. But by and large, I think people who do it well know what to do. The one general comment I would say is that all minority groups need more face time and more personal messages. And we're coming up on some big issues with the All of Us research cohort, the previously called Precision Medicine Initiative, that will also, we're working closely with them on this. We generally think minority scientists are generally better at it, although there's no empirical evidence on that, and I think there's greater granularity that is needed. But also need to end this myth that it's too hard. It's that the barriers are too many and you just can't do it. Which a lot of mainstream investigators have that belief. In the diversity of the workforce, we haven't made nearly as much progress. We are in a crisis mode, I believe, as a profession, both on the clinical side and on the scientific side. On the scientific side, 5 to 7% of funded R01 grants are awarded to African American and Latino PIs. And you say, well, what about American Indians? Well, they barely register. And you probably have a significant proportion in this room. And that's embarrassing. Pacific Islanders are the same way. And so this is something that NIH is very aware of. Hannah Ballantyne is, I think, leading efforts to do this. There's apparent funding bias for African Americans that have been well described. And we've reanalyzed all the data, and I think it's very consistent. One of the easy intervention points is that people need to resubmit their grants. I think African American investigators were half as likely to resubmit a scored grant compared to their white counterparts. So there is a pipeline issue as well, but these are complex, and there's also a perception that underrepresented minority PIs are submitting grants in low success topics. And of course, low success topics include minority health, health disparities, and some things like hypertension and kidney disease. In the med school or the clinical workforce, we've made a little bit of progress, but you can see 5% of the 2014 graduates are Latino, 6% African Americans, less than 1% American Indian. And we have reasonable empirical evidence that if you train more minority physicians, they're more likely to care for uninsured and Medicaid patients, and they have a greater intent to work in underserved areas, regardless of their specialty orientation or their debt burden, which are both important in determining this. So NIMHD's priorities really, as I look forward to the next several years, had been focused on defining the science, sort of establishing these definitions or these working definitions for the field. I came with this. I think there was a moderate amount of conversation and confusion about some of the terms, but I've now tried to be consistent in all the councils, and in fact, at some point I'll have to come up with new slides, right, because I use the same ones. I modify the same ones for every talk I give when people want to know what NIMHD is about. The strategy to get there is to really promote you to develop your science and to apply to us for R01 applications. That's the principal currency at NIH is R01. Doesn't mean we're abandoning other things at all, but we do need to stimulate that. And I think a lot of scientists have gone to other institutes. We get a modest number of R01 applications, but still far lower proportional to our budget than other institutes get. We want to look to collaborate with other institutes to build networks and to use and leverage resources in other institutes, and also, of course, continuing to work on diversity of the profession. In our extramural scientific programs, we've functionally organized into 3 areas. They're all interrelated, but they are distinct. One is clinical and health services research, and Regina James is our director there. It's to really focus on everything related to what happens in clinical care. A second one on integrated biological and behavioral sciences is more sort of basic etiological mechanisms. Again, all related to humans, not basic science, and Mike Sayer is our director there. And on the community health and population health sciences, Regina is acting. We're going through a reorganization, so until the reorganization gets through, which is not going to happen right now, but hopefully this year it will, we don't know how, what the final outcome of these are. But you get the topic that we want to focus on thematic areas, get program scientists in these groups that are experts or knowledgeable in these areas, and work with you to get the best possible grant applications come to NIMHD. Let me switch and say a few things about sort of the big picture. Not a needle we can move very quickly, but I think it's good to take stock. This is from the census, and it's sort of a stark reminder of the relationship of wealth, socioeconomic status. In this case, it's annual household income, which is just one metric of measure of wealth. It's not necessarily always the most accurate, and mortality, the ultimate outcome, right? All-cause mortality. So you can see that if you're below the poverty index level, you're 3 times more likely to die than if you have a household income of $115,000. The U.S. Median income right now is about $50,000, and I think most people would think $80,000 sort of defines what people would call more middle class. At least at University of California, a student can get a complete support if their household income is under $80,000, if they use that as a metric. And you can see this relationship is very powerful, very consistent. We've known this for a long time. The Whitehall study in the United Kingdom published it based on occupation, but it is just a reminder. life expectancy has gotten a fair amount of press lately in the last couple of years, mostly because white Americans have lost life expectancy, and that's been the big news. Nobody ever cared about the other groups, right? So what we saw was that white women in particular lost life expectancy. Started to happen about 15 years ago. Mortality rates were going up, and then men also were observed to have the same thing. The byline, though, that to remember is that all of that is social class. It's poor people, poor whites, who are losing life expectancy, not upper middle class or wealthier individuals. African Americans, on the other hand, have gained years of life expectancy at a rate that's faster than anyone would have predicted. So the models in 2000 would have said 2% per year annual gain is what we expect based on how things are going. It's been 4%. So the actual gains that African Americans and blacks have made in the U.S. in the last 15 years are very palpable. The needle is moving in the right direction. We're doing some things right for that community. The Latinos are sort of aberrant. They do well even though they're poor, and immigrants, their years of life expectancy, their life expectancy is the leading for men and for women. If you look at Latinos in the U.S., map them to the other, quote, developed countries, high-income countries, Latinos in the U.S. look like Germany. And so no one understands this yet, but it's there. And the data for American Indian and Alaska Native and Native Hawaiians is actually not national data. This was presented by Elizabeth Arias at a meeting I was at. She's part of the census, National Center for Health Statistics, related to the CDC. They haven't yet vetted these and published them, but they will. And you can see the stark differences in lower life expectancy for men compared to white men by over 8 years, and compared American Indian women compared to white women by almost 7 years. So there's work to be done and to improve things. A group of economists led by Dr. Chetty in Stanford published this paper last year in JAMA and got a lot of interest. They very creatively, cleverly matched tax records to the death registry of the Social Security Index. They showed what we've known for a long time, that the richest versus the poorest, 1%, there's this big gap in life expectancy. For women, it's 10 years. For men, 14.5 years. Their novel messages were two. One, the inequality does not appear to be decreasing. If anything, it's increasing. So that's a big concern. So the poorest people are doing worse compared to the wealthiest people. Now, it's the 1% versus the 1%. And you say, well, that doesn't include probably no one in this room, I would guess. But the other message from this analysis was that they found that the bottom quintile in some areas lived 4.5 years longer, 3 to 4.5 years longer than in other areas. Now, what was that about? So the poorest people, the most vulnerable, 20% in Manhattan or Birmingham, actually did better than the most vulnerable in Detroit. Or other areas, and they had a rural-urban contrast that was similar. So what was that about? It wasn't individual behavior, as the economists tried to explain with their models. Something about those communities, we're doing something right in some places that is allowing the most vulnerable people to live longer. So we have to know what we have to figure out what that's about. And sometimes these big, giant studies help us focus on the areas that need work. This is a quick snapshot of rural America that the CDC published earlier this year. So heart disease, cancer, chronic lung disease, accidents, and stroke all have higher mortality for rural America compared to urban. And again, an emphasis that is of relevance to NIMHD and important in this area as well. This paper was published in Lancet in January. It is from the National Cancer Institute Intramural Program, again, looking at national available data from the National Center for Health Statistics and Census, and creating these age period cohorts retrospectively. And they showed that whites and American Indian Alaska Natives have increase in premature mortality. Now, premature mortality, by definition, is if you die before 65. And this is only adults, so I guess it's all over. If you're 65, you don't count anymore, right? That's sort of an old model of, productive years. We know this no longer applies, but it is a metric that is used in public health science. And the causes of death, the reason for this excess premature mortality, were related to accidental overdoses, felt again to be related to opioids in large part in some groups, chronic liver disease and cirrhosis, and suicide. It was the worst for women at age 30. So women were more vulnerable in these data analysis. Again, consistent with all the data that have been published on this for about the last decade. And you can see the increase peaked at 2.3% increase in premature mortality for white women in the age cohort at age 30. For American Indian and Alaska Native women, it was 4% increase. Now, again, the flip side was that there were marked decreases for Latinos, for blacks, and Asian Pacific Islanders, mostly from control of HIV, the improvements in cancer, and in heart disease. American Indians and Alaska Natives had the highest mortality, absolute mortality, and African Americans were second in this analysis. Suicide, again, the MMWR report just last month illustrating that for whites and American Indians, the rates not only are the highest, but have been going up. And they're going up over the course of this 20-year period by about 20 to 25%. You can see that for blacks, Asians, Pacific Islanders, Latinos, there are similar slight differences and more or less stable. There are some heterogeneity within the Latinos and Asians for sure, but this is, I think, a very telling statistic. I would say for American Indians, we've known this, and I know there's been a number of studies that have tried to focus on this. On the other minority categories, I say, well, why is this? We should find out why there is protection from suicide and what are the causes of that. It's something to advance knowledge because it may really help us understand how to address other problems as well. Infant mortality, we've seen steady progress over the last 15 years. I tried to update these on my computer yesterday, but it is through 2014. Highlight again that for blacks and Puerto Ricans, which started off with the highest rates in 2005, 2007, the decreases have been most marked. For American Indians, there's been very slow progress. In fact, their decrease was the lowest proportional decrease. We know what to do to prevent newborns from dying in the first year of life. And this is, I think, an area where the United States can do better, has done better in the last 20 years, and we should continue to push on this. Why African Americans have disproportionately higher infant mortality is unknown. It's been a persistent, vexing challenge for researchers who have tried to look at this from different perspectives. Immunizations for children. With funding and campaigns, we see over 90% for all groups. And this is all including hepatitis B would count here as well, would be included over 90% now. In fact, if anything, it is more white, upper middle class who are now resisting and sort of saying, well, maybe we don't want immunizations. And again, this is a more recent development in the last 10 years. And you've seen measles outbreaks in affluent areas and recent mumps outbreak. And so I think this is, again, an area that could merit from research. Recently updated cancer screening from National Health Interviews Survey. Rates are flat. So the issue with breast cancer screening, mammography, there's been some reports about, well, it's not as good as we think. It's fairly flat. You see American Indian and Alaska Natives are lower, though, at 56%. Staying around 70, 75%. They've been in that ballpark now for about 10, 12 years. Again, a socioeconomic status gradient with less educated having less likely to have it. With colorectal cancer, we've again made progress. We're up to 63% with whites, and blacks are not that far behind. They do have a higher rate. And you see that for American Indian and Latinos and even Asians, the rates are still lower. And this is any colorectal cancer screening test. So a fecal occult blood test, or a colonoscopy, and the fecal occult blood test within 2 years, not within the past year. You can see a gradient again by education and again by insurance. Mexicans are the lowest, in part because of the highest rate of uninsured in that subpopulation of Latinos. NIMHD funds a number of studies on American Indian, Alaska Native health. This was a portfolio analysis for 2015, 78 projects and sub-projects, just shy of $19 million. It's just under 10% of our grant budget, not our total budget, of what we dispense that isn't pre-allocated already. We have a certain amount of money that we give in grants that is mandated by Congress that be given to a certain program. And I think the variety of mechanisms are evident to you, and that we need to get more detail about content and see, are we matching the problems to the grants, and what are we missing to encourage you to apply. This is a portfolio analysis done by NIH, the Office of the Director. We had some slight differences, so I separated out the total one from the NIMHD one. You can see about 2/3 of it is health research, so science, and the rest is either in workforce development or capacity building and community outreach. And the total budget is about $158 million out of an NIH budget of grants that's somewhere $28 billion or something like that, so to give you a sense. These are the institutes. And you notice that general medical sciences is first, a lot of that related to infrastructure and workforce development, and NIMHD is second, and most of ours is on focus on science. And you could certainly use this or refer to this and the Office of Tribal Health Research on this topic. This is the distribution around the country. It's too hard to see, I know, but I think Sioux Falls in South Dakota is there with a modest circle in red, and around the rest of the country as well. Just quickly take you through some sort of quick stories of things we funded, just to illustrate a few more points. I know I'm probably running out of time. Here's our friend Spiro Manson and Linda B., who is on our council. And to honor of Native American Heritage Month in November. I believe this is going to be presented later, and I use it as a point to illustrate, what an important area this is. Kidney donation and transplant. It's a life-saving intervention that gets you off dialysis. And as a general internist at UCSF, I had a number of patients with kidney transplants, because that's a quaternary care center, so I would get those patients to be their primary care doctor. And the barriers to go from chronic kidney disease to a transplant are enormous. You have to get to a place that does it. You have to fill out all these forms. I mean, it's huge. So I think understanding those pathways and helping make them easier for patients. We know that there's huge disparities in access to kidney transplants and the variety of factors that lead to this. So this is the kind of work I think that will help understand that. This is also from this center. It's the unconscious bias aspect in emergency department care. I know that there'll be a presentation on this, so I won't dwell on this as much. But again, illustrating the idea that in that patient-doctor interaction, patient-clinician interaction, a lot of good things can happen, but also bad things can happen, and disconnects can happen. And this is a case where in an emergency department, the more clinicians were exposed to American Indians, the more likely that their biases were reinforced. Not just because of the kids, but also because of the caregivers. Interestingly, there was the younger clinicians were more likely to be biased. Just a sidetrack to talk about racism as a scientific topic. We mostly have worked in, work has been done in the interpersonal sphere, so people report on perception of discrimination based on their experiences, whether the past month or your lifetime. There are good measures that David Williams and others have worked on and that you can use that are not difficult to adapt to a population. Structural racism is a tougher one. I'm not 100% sure it's a research construct versus a systems construct or concept. It relates to all the history and the culture of institutions. the codified practices that really have perpetuated inequality. There's also history involved, the historical trauma that different populations have undergone. And again, how do you measure this? And we're going to try and get at this in a scientific workshop next month. And then internalized racism, about how does this discrimination or structural racism that you've experienced, how does it affect you? And these people don't even have an insight that they have experienced racism, but they've internalized it. And it maybe has to be measured in different ways, biologically or in other behavioral ways. It's also the vigilance that people report, sort of the anxiety of being in a situation where they've had problems, have had bad experiences, and then anticipatory vigilance in those circumstances. So I think this is an important area to apply scientific methods to understand mechanisms of why we see some disparities. And people say, well, how does it harm health? Summarize the measures, and there's data on observational data on affecting mental health, particularly in African Americans. I think conceptualizing discrimination as a form of chronic stress that then we know has some effects on the physiological system, and trying to study it, trying to add that dimension to the study of this topic. And developing the different measures that can look at this. People have looked at cardiovascular effects primarily, or inflammatory markers effects. There's also some good studies linking it to mental health effects and health behaviors. A lot more work on health behaviors. We did some work on this in South America on smoking in racial insults leading to more smoking or drug use among indigenous youth in the north of Argentina. And then linked to other disease outcomes really are still not very robust, and I think it's an area that needs work. This work from Alaska, I think the reason, I won't read it, but just to say, for everything that people say, well, we have an answer. This is how people quit smoking, and this is how people go sober in terms of their dependence. And it's almost always data that was generated from white studies. And yet, because a lot of these processes have cultural differences, they have biological differences in some cases, we kind of need to do some of the research again. So it can be a starting point, but you have to kind of, what's the experience? And this is what this study, I think, captures, is what's the experience of Native people who were alcoholics, and what they recall on their experience of getting to sobriety. And I think it's important to value this kind of work. Similarly, with smoking, there is a assumption that smoking is an addiction, right? It's a paradigm. So you smoke, you're addicted, and you smoked in order to maintain your nicotine level receptors in the brain. Well, it turns out that actually a number of people who don't smoke every day, by definition, aren't addicted, right? Because they're non-daily smokers or very light smokers. And perhaps there's other mechanisms that actually exist that explain why people smoke. And I think it has to do with this sensation-seeking, sort of this peak effect. And there is now some data on physiological measures that indicate that you can smoke, you get your saturated, your receptors in the brain that make you feel good, and then you don't have this need to continue. And that pattern, I think, is actually much more common among all minority groups. Diabetes is a disease we've all gotten to know is disproportionately affects all minority groups in the U.S. Perhaps American Indians having much of the initial data on reporting it due to the work that was done in the Southwest. And this is one analysis that indicates that. But one bit of good news from the CDC earlier this year, again, showed that for end-stage renal disease, diabetes-related end-stage renal disease, there's been remarkable improvement in American Indian and Alaska Native rates. They're still high. In fact, they're now the second. They're now no longer the highest. They're the third highest. But a big drop, over 50% drop in this. And here's an example of we know what to do. If you have diabetes and you have a creatinine, a glomerular filtration rate of 35, so you're already in advanced kidney disease, but not terrible yet. Dialysis is 15. We know that if we give you a certain class of drugs, we can slow that down. We know that if we really control your blood pressure to a certain level, we'll slow that down. And there's some dietary interventions that may be worth trying, besides the other issues of maintaining symptoms. And yet, we know that that delays before we used to say, well, you get to that point in diabetes, in 5-6 years you'll be on dialysis. That's what I learned as a resident. And you can now make that from 5 to 6 to 20, 25 years. And independent of the transplant option, which may also be. So I think this is an area, again, where we can do a lot better. And finally, on the accidents, and this is, I thought, an interesting project about proper restraint and using proper seating for children in vehicles. Since, unfortunately, accidents are disproportionately affecting not just the American Indian Nazca Native community, but also Latinos and most minority communities are also disproportionately affected by this. We have 3 scientific workshops that we planned shortly after I got to NIMHD. These were driven in part by questions that I didn't think we could answer through a grant mechanism, and whether or not we wanted to do grants on this. The first one we already had, which was in October, related to genomics identifying race versus self-identified race. And we're working on a report from that. The genome was a strong partner on that. We're going to have 2 in May, on May 10th, 11th, or 11th, 12th. There's one on information technology and minority health disparities. And the structural racism and cultural competence one is scheduled for later in May. And if you're interested, let me know. These are a number of funding opportunity announcements that we have released in the last couple of years, or developed and released mostly in the last year. The immigrant population one has been out. We got our first group of applications there, and that'll be open for 3 years. We had a good response to the disparities in surgical care and outcomes. Again, these grants just came in, have been reviewed, and we haven't yet funded any under this. Social epigenomics, the same thing. We have one that's working its way through on the Caribbean initiative. The idea is to fund studies in the Caribbean where the home populations of immigrants to the U.S., so Black Caribbean islands as well as the Spanish-speaking islands. Sleep Disparities just got published last week, partnering with Heart, Lung, and Blood. We have one out on chronic liver disease and liver cancer that came partnered with NCI and also alcohol. And then we have one that will be developed, that is developed and working its way through on research with the tribal epi centers. We're looking for the partners within NIH and have a couple of institutes who will join us on that. And that's going to be directed to the epicenters, partnering with a more research-intensive organization or institution. The idea is to support their research work in these centers. Last thing is to plug our Disparities Research Institute. This is from last year. This is what NIMHD used to call the course. And I didn't want to do the course, but I did want to do something to develop the future investigators applying to NIMHD. And we had 51 people accepted last year. We had almost 500 applications. They spent a week. We support travel, but not per diem and hotel. You can see from this photo that we had it was a very diverse group. We had about 13 physicians, 5 nurses, and even a pharmacist. So not all PhDs. And we're announcing it for August of this year. It's a lovely time to be in Bethesda. So it really sort of promotes being engaged in the course. And probably the mock review was the most popular thing that the scholars experienced, because they probably hadn't been through that process. We used real grants, and this time I think both funded. Last time was only funded grants. This time we're actually going to use unfunded grants as well, so they'll get to see what happened with that. Lots of other institutes collaborate and send their program scientists. So I encourage your early stage investigators to apply. This is really targeted to postdocs and assistant professor equivalents. We can also consider people who are more advanced, who kind of got late start to doing research. The online application is open and it's due May 12th, so do promote it. So I think that's it. I don't know if I left any time for questions, but if you let me, I'll happy to answer questions. Thank you very much for your attention.
Questions? Questions?
Hi. Is this on? Yeah, okay. My first question is, I have two little ones. You said that one of the priorities of NIMHD is to promote innovation and work toward getting people to be able to submit for R01s. What types of things do you do to promote before someone applies for an R01? Besides that the Institute, I mean, that seems like a great resource there, but are there other ways that we can work toward more R01 applications?
Yeah, and if you go, am I on? If you don't mind telling me your name and where
My name is Clayton Hilmert. I'm from North Dakota State University.
Great. So I think you're asking about, are we going to do like a K program? Or
specifically, my second question was, you didn't have R15s listed up there as a way to get funding through NIMHD, so I was, as North Dakota being eligible.
Even though I've been there 19 months, I still get lost in some of these acronyms. Acronyms are bad in government. I should have put that up there. And I try to encourage people not to use them. But you fall in the trap. So R01s, RPGs, our research project grants, R01s, R21s, R03s are sort of the gold standard. And of that, R01 is by far and away the most important one. R21s are a mixed picture. All these PAs I showed you, all these program announcements include R21s. But R21s are used differently by different institutes. I had this delusion that they were like starter grants, so don't quite have the idea to go for an R01. They actually have a much lower funding success than an R01. And new investigators tend to be hammered in an R21 because a lot of senior people are applying for R21s and review committees are expecting people to have preliminary data even though the guideline says you don't have to have it. So I would encourage anyone that thinks they're ready for applying for an independent grant, they should apply for an R1. And also new investigators get extra points. R15s, we get those, we fund them. They go to certain states, so I think it's not a generic one. So, and we do, in the batch I got about the June council applications, there were a number of R15s in there. So they're definitely part of it, and they're like an R01 in terms of budget. And I think prestige for the investigator. We do have, I do have in mind developing a K program at NIMHD. I think it'll be more in the K01, K08 kind of model. It will probably come out of some finite part of the budget. I think there is room to carve it in there, at least to start with. I also encourage people to submit diversity supplements. So if you have a center grant or an R grant, you can get a diversity supplement. And my mantra on that is we should fund every single one. That we don't really have a strict process. We don't get enough, actually, to be honest, to make it that selective. And program will come up with 5 reasons why this should not be funded. And even though they're doing good work, and I go, diversity supplements we should just fund. And I think that's a lot of the attitudes for other directors. Other big institutes have a limited budget on what they spend on diversity supplements, but they're pretty, 50% get funded across the board usually, and they're underutilized in terms of a mechanism for it.
Thank you for your presentation. Can you hear me? Okay. I was struck by your slide on workforce diversity, and that there's fewer PhDs or MDs that are applying for grants, or fewer that are getting them. And so everything was sort of focused on that aspect of it, but as part of the system, it's also the reviewers and how they're looking at grants and how they're marking them. And some of that comes from where they know and what their research paradigm is. Can you speak at all to what sort of training might be going on with the reviewers? You know, they're all more senior, so it might be difficult to do that, but a lot of them don't know exactly, I don't know, maybe be stuck in what it is that they learned and not really, you know what's sort of up with the innovation, or I'm sticking my foot in my mouth, so I'll stop there.
Great points. The diversity of the scientific workforce is complex. I haven't actually reviewed the data in detail, but I'm told by people who have been looking at this more recently that the pipeline issue, which has always been forever and ever the issue that we've talked about, is no longer as dramatic. That maybe not for the clinical workforce, as I mentioned, but that that people, young people of color, are going into graduate school, and they're getting PhDs in science. Now, it may not be proportional yet, but it's no longer like this, oh, it's so few, we can't do anything. You know, the pipeline, you know, people throw their hands up, well, start with high school because and so we're now further down, you know, the barriers are now at finishing, getting a job, you know, getting a postdoc. And so I think that the leadership has to really emphasize that. That's where I have expertise in getting postdoc forward. And my philosophy was always, well, if you got someone that far, you really develop them, protect them as much as possible, because those are valued individuals that have got that far. Review is a huge issue, and it's complicated. My one-liner on it is that I think most reviewers who are really, you know, do a lot of hard work and dedicate time to the effort, and believe me, they don't do it for the $200 a day, don't see the forest. They mostly focus on the leaves or the branches, and they're dedicated to finding flaws. And I would say that the non-basic scientists actually are much worse at are worse at doing that than the basic scientists. Oh, the sample size, oh, this or that design. And so creativity, innovation, you know, sort of out-of-the-box ideas, taking a chance on something is not standard. And sometimes you get these grants that get great scores, and they're kind of, they're not that interesting. We can't fix this overnight. I think Richard Nakamura at Center for Scientific Review is very interested in making things better. For NIMHD, personally, we are going to increase the number of R01 grants. We don't want our R01 grants to get scattered across all these review committees where people are going to say, oh, what kind of science is this? Which is one of the risks that could be happening. We don't fund grants on the basis strictly of score, but you have to be scored. We can't do anything if you're unscored. But within a range, and a lot of institutes are doing this now, we say we have a pay zone, and where we'll consider your score as one important but not exclusive factor in deciding to fund. Reviewers, I don't know what their mean age is, but you have to be in a standing review committee, you have to have been funded with an R01. And so that already is selective as to who is there. And, you know, if you ever get asked to do it, do it. It's work. Even an ad hoc committee gives you a sense of what it's about, and it gives you a flavor of the kind of things that people do, and that'll make it better. But it is a big work in progress. It's a topic of ongoing discussion all the time amongst the directors, and particularly in the case of Richard in the Center for Scientific Review. So.
Thank you so much.
All right. Thank you for your attention.